And that's something I thought would be good to kind of dive into right away, because I'll be honest, when I graduated, I had the three-phase degeneration model, and I never liked using it as a hard sell, or if you don't do it, this will happen. But I had it on my desk, and I did use it. And then I kind of stumbled into the pain science stuff about 10 years ago, before just, I was into it before it was cool, before it was trendy kind of thing. But it really messed me up. Okay, so hey everyone, I'm here today, special guest. I've not really done many of these before. So this is Dr. Jerome Fryer. Many of you may know Jerome. He's a creator of Dynamic Disc Designs, which is a very, very cool company. He makes these models here, which I recently got my hand on, which are very different to your typical, like, here's a bulging disc, your three-phase degeneration model, that kind of thing. And we're going to chat about these and how we can use these to actually educate patients in an evidence-based way, in a patient-centered way, whilst avoiding, a lot of the reasons why many of us, I think, myself included, kind of shied away from models. And that's something I thought would be good to kind of dive into right away, because I'll be honest, when I graduated, I had the three-phase degeneration model, and I never liked using it as a hard sell, or if you don't do it, this will happen. But I had it on my desk, and I did use it. And then I kind of stumbled into the pain science stuff about 10 years ago, before just, I was into it before it was cool, before it was trendy kind of thing. But it really messed me up. It mucked up all my paradigms. It didn't give me a new one. But one of the things that came out of that was I stopped using models. I can remember really clearly going, hang on, they've got this big bulging disc. I'm going to yellow flag my patients. I'm going to nocebo them. They walk in, they see that thing on my desk and go, oh God, what if that's me? And I think, indiscriminate use of pathoanatomicals, we've had a chat, you and I agree that's not a good idea. But it's got me wondering. I think I threw out the baby with the bathwater on that. And now I've got my hands on this. I can see how it's different. I can see how this is not the same as a typical model, and there's a lot more cool stuff you could do with it. But I'll be honest, I'm a little bit of a fish out of water. It's like I haven't used a model for quite a while, and how does that work with you? How do you fit this in? Because I know you're fully aware of this shift away from models, this shift away from pathoanatomics. How do you reconcile that with empowering patients and not kind of scaring them and freaking them out?
Yes, it's a new baby, right? And so the main thing is it needs to be in context. So if a patient has a particular movement, this is kind of how the dawn of the company basically happened when a patient came to me and she was crying because the doctor had given her a diagnosis of degenerative disc disease, right? Just like that. You've got degenerative disc disease. And the patient came to me and she just started crying. She was quite mobile, and, and it was just like, whoa, wait, hold on here, So at that time, I didn't have a model to show what subtle disc height loss is, right? That, right? This and that, there you go. You've got degenerative disc disease, right? Because you've lost some height, you've lost some water content in the disc, and that's it. It's nothing more than that.
Yeah.
Right? This is how radiologists report this. So I was like, wait, I don't have an aspect of a model that it could show the time height loss of the disc, over time. Why do the symptoms vary in the morning and the evening? My back really gets sore in the evening, why, and then I feel like I got to sit down, as the facets approximate, they have to sit down. So it's these subtle motions that, like this could be symptomatic, or that can be symptomatic, or it could be a therapeutic direction. Is this relieving when you bend your back this way? Is that relief? Yeah. Okay. So when I'm, prone Mackenzie, okay. So bending it back that way actually helps with perhaps the retraction of the nucleus. And, okay. So you can see it's really case specific.
Yeah. So you can, that's a really cool point. Straight away, you can go, look, this isn't like your spine like it is for everyone. So you could be here, you could be there. Because that's the thing I love about it. Although I'm still learning, it's like, it is, I mean, dynamic disc designs, right? That's the perfect name because it moves, you can play with it. Yeah, so you can actually just demonstrate subtle things that are moving and see how the rest adapts to it.
Well, yeah, if somebody has symptoms, for example, they're in a standing posture and you go through their active range of motion and they bend forward and they go, oh, that's sore. As a doctor, you should have a way to explain that. Right? Oh, right. So you have to, for me, it's like, okay, well, you start building a case for the patient. You grab the model and say, okay, yeah, what's symptomatic when you bend forward? They're going to go, oh, that's forward. Okay, wait, hold on. Is it that simple, right? How about if you basically maintain your hip, you hinge through your hips,
hip hinge, yeah,
and to avoid that sort of that folding on that disc. Is that symptomatic? No, that actually doesn't hurt. So it only hurts when you go on. Yeah. Oh, so now you've got a platform. You've just had them understand their movements and their symptoms, right? Whether or not you can tell specifically whether it's a annular fissure, right?
Yeah.
Or whether it is some shearing that's occurring as they flex. Could it be facetogenic? Whether it's a little bit of a bulge it doesn't really matter because you're not quite certain yet.
As so you're kind of working this out with them and using the model as you go to go, okay, when you do that, this is happening. Okay, then we've tested this shearing, we've tested compression. So you're kind of walking them through your thought process then.
Right. And they're engaged. They're at the center. They're like, you know what, doc? Yeah. When I do this, it hurt. Oh, so when you do that and then, okay. So what's the spine doing when you're doing that? Let's see. Okay. So when it's doing that, then it's bending back like this. You get like pain on one side that kind of goes into the butt here, right? And it's a little bit more when okay. Well, you know what? There's a high probability it's just the facet joint. Well, what's a facet joint? So it's about getting them to understand their movements that hurt, whether it's static sitting for a period of time, right? And then getting them to go, okay, well, you know what? Maybe I know what to do too. Yeah. And I'm going to be a partner in this.
Yeah.
Right. So there's that therapeutic alliance through our education.
Which is funny because that's something that we bang on all about in terms of like contextual effects, and it's all about education and patient empowerment. And then we shy away from stuff like this because we're like, oh, that's been misused in the past, we shouldn't do that. And like I did the same. I was like, you know what, I'm going to use pictures because they might be less scary. And funny thing is that there's a paper I read last year saying what do patients with back pain want? It's like they want a structural diagnosis. Like we're going like, oh, I don't know we should be doing that. I don't know we can do that. But the patients are like, that's what they want. So yeah, already I'm kind of seeing this like, okay, you can just kind of, this could be part of your exam, right? It's not, okay, sit down. Here's your report of findings. I'm going to tell you what's wrong and this is what's happening. Like, I imagine you're picking these up a few times as you go through that whole process.
Exactly. Right.
Yeah.
As they do a movement, I don't wait until, I get my whole exam and say, okay, report of findings time. It's like, and every case is a little bit different. We all know that it's nuanced and they have questions. And sometimes, you've got to show them a movement strategy during the exam. You get into therapeutics even before you get to, so it's about just reading the patient and kind of reading their symptoms. And there are some cases where I don't even pick up the models because they don't even want to know. They don't even know. I don't even want to know. You know what? All I want to know, tell me the exercises, you know what? And those exercises really help. So as time goes on, then I'm like, why those exercises help? Well, why? Right. So it's fluid.
Yeah.
But
no, I like that. You can kind of work it out as you go. There's like that you're exploring together. I know for my patients, they love that when they see curiosity. It's like, okay, let's see if we can work this out together. They're like, you're not sitting here pretending you've got all the answers like all the others did.
Right. And it shows that you're interested, you're engaged, and you're dedicated to finding a solution for them.
Yeah. No, I really like that. And like I said, this is I think that's why I think a lot of us have shied away from models, because, you know, there's been this move away from pathoanatomics, and, you know, it's like, it's not as simple as, oh, this test means this disc bulge or this test means that facet. So we've kind of gone, well, you know, physical examination, it's a gray area, there's uncertainty. And, you know, all the models I'd ever come across were like, they were certainty models. It's like, this is the thing, it shows one thing and that's it. And then you have to go, well, yours isn't really like this, but this is kind of, but it doesn't matter because that's the image they've got burned into their brain then. But yeah, the idea of something where you can, I mean, I'll see if people can see it a bit better. You can kind of, you can move, you can play with it, you can get that shear going on. The really cool thing as well is I'm going to try and show this properly now, because for a while I was like, there's this section in, let me turn off this light actually, that might make it a little easier. You can see that red section in there where if you compress it, you can see the nucleus bulges out. I was struggling with this because I was doing this all the time. Like, it's not bulging, I've got to really, really squeeze it. And then I mentioned it to you and you're like, well, yeah, you're dislocating the facets when you do that. I was like, yeah, oh, right. Yeah, there's actually ligaments there. Whereas when you hold it and then compress it, that works really well. So it actually, it's so realistic a model, it wouldn't let me use it in an unrealistic fashion. It just, it's like, no, that wouldn't work. So, yeah. And being able to show that dynamically, I think is really cool to go, yeah, you may have an extrusion, but look, like, there's the, I'm going to do it wrong now. There's the extrusion, but when we decompress, like when you go back to neutral, that's fine. And we can squeeze this here, not a lot happens. You know, you want to get that spinal stabilization exercise going, that sort of thing. So, I mean, that's just one, you know, this is not the, I know you've got models that show way more detail, way more features, but even just this, they can visualize the facets, they can visualize that subtle movement that's going to be happening. You can demonstrate shear without, you know, dislocating a disc like my previous models would do. So I love the fact that you can adapt this and you can respond it to the patient. And it's interesting, yeah, you don't use this with everybody. Like you'll have some where you're like, you know what, they're not into that right now.
Well, in the beginning, yeah, it's true. In the beginning, you know, I'll kind of encourage them, like, you know, they're, you know, like this is, so I just get a read, right? You start to introduce ideas, you know, like for example, maybe they're curious, you know, why their back continues to kind of trigger, you know, when they go into flexion or when they go into extension. Like this one, for example, is a hypermobility model. So we know that manipulation is helpful, of course, right? You know, you could teach them and show them, you know, what manipulation actually does by gapping the set joint, right? And I do have manipulation models too, and that's
I saw this. You've got one that has the audible release. Yeah, that's
and that led to a couple papers actually, the MRI paper and also another paper that actually I think I've revealed the audible mechanism. So it's kind of it's yeah, it's fun. So, but this one, we know that not all discs are equal. So when somebody bends, for example, can you tell which segment is moving a bit more?
Yeah.
Right? So if somebody bends and they fold a particular segment, well, what do you think's happening to facet joints, right? You can see how.
Right? So that's your segmental instability. That's okay. You've got.
Yeah. And I don't use the word, you know, we've been kind of coached not to use instability. It creates fear avoidance and things like that. And, you know, so, you know, I talk about stiffness and how different tires in a car, one if the pressure's down a little bit, may move a little bit more, you know, and so to help them understand that something is just a little bit, maybe a little bit extra mobile.
Yeah. And it's nice. I think that's reassuring because from, you know, I imagine a lot of patients, they think, oh, that joint moves too much. They're thinking it's popping out of place. You know, it's gone out of place. Like, my back's out of line.
Like gone.
Yeah. Whereas with that, it's like, this is what's going on. Like, yeah, you can, and it's nice putting that in context of that one. So you can go, look, the others aren't doing it. So it is different. But yeah, there's some small movement. Right. That feels like a more manageable problem, right?
Right. And why does manipulation give you temporary relief or even longer relief? Because, you know, if you adjust the segment just adjacent to it or below it, now you've freed up motion at that segment below, and now you've got better motion sharing across the joints. So if manipulation is therapeutic and you get an outcome for like a couple, 3 days or a week, it helps diagnostically too. You're like, okay, well, maybe there's something else going on. And if you just kind of, instead of them, leaving and saying, that didn't work because it only lasted like, 4 or 5 days, you start to talk about what manipulation is and how it can influence and why is there a positive outcome. And, so, yeah, it's, there was just such a need for this, right? Such an important need to help give us tools. It's like a carpenter, do we just have one big sledgehammer when we go to build a house? You need different tools.
Yeah, because we talk about that all the time, like if you're holding a hammer, everything looks like a nail. If all you can do is adjust, you'll adjust everyone and that's it. But this is the first time I'm thinking of that in relation to the models. Like I knew people who had a few models. It's like, yeah, because they had a neck model and a back model and a knee model and an elbow, but it was one model for all of them. So it's like, yeah, I think that's maybe why we kind of shied away in the same way we might shy away from cookie cutter treatment plans or everybody getting adjusted and that's it. And that kind of blanket care, because our models were kind of blanket explanations. I mean, the idea of one that can explain several things on its own is very cool. But then, like you say, to have one that's showing hypermobility. I mean, how many models do you have? Because I can see you've got quite a few in the background there. That's like a stenosis one, is it there?
Very good. Yes, exactly. Right. So Stenosis Model, you can see that the IVF is narrowed, right? So what do these patients typically do to bring relief? They sit. So you can see how it opens the IVF, right? And then conversely, when they walk, see how it narrows?
Yeah.
Right. Interestingly, too, when you look down the ligamentum or down the canal, the ligamentum flavum has been thickened here. And if you put a little pen up in here, you can feel the friction. You're like, oh, and then you get them, you compare it to help them pull the product corner, and you could say, okay, see the canal here, right? Versus here. So much more narrow it is. And then,
so you may even use two different models there, yeah.
Yeah, and then you put this up here because it's, it's really tight. Okay, so let's take this into flexion, and then all of a sudden the pen frees up. And look how subtle this is, right? I'm moving it apart that much.
Yeah.
That much that is going to free this. That's how amazing this is. Subtle flexion will open up the canal ever so slightly. And that's what's helped me too. These models have helped me as a clinician understand the small changes and how significant the symptom change can be for patients. And that helps. There's reassurance too. They're like, oh, okay, so maybe that's something I can do about it,
Yeah.
So
it's a small change. I can do a small change. I don't have to try and open this thing up and all that kind of, because that's what probably leads them to think surgical approaches, right? It's like, we need a big change. Well, I'm going to have to go to the guy who's going to cut it open and stick bits and wedge bits and glue bits and take bits out.
That's right.
Yeah.
Give them scale, give them realism with movement, right?
Yeah.
And that's where dynamic disc designs is really a bit of a sort of a play on words, degenerative disc disease too.
I heard you. I think I heard you on a podcast recently. I was like, I never connected that, but DDD, that's a very clever.
And 3 dimensions, that sort of thing. But it comes down to just how dynamic that disc is over a lifetime. You could talk about over a lifetime the changes. The stiffness that kind of ensues and, over after micro injuries or what have you, after disc herniation. So yeah, it's been fun and it's very exciting because it's hard to keep up with sales right now, right? It's that's worldwide. It's but there's like people are craving it, right? I think that's what it tells me. Right.
Yeah. So, I mean, I know for myself, moving away from pathoanatomical stuff and moving away from models and moving away from structures and that sort of, it leaves you in this kind of limbo of okay, well, now what do I have to explain it just using words and kind of vague. And you can see some of the patients, they're like, my last guy said it was a disc. I know, they know what that word means. They know that it's a thing. And, I didn't do this, but I know people who try to explain non-specific low back pain to patients. And that is enough. you know, they have their success stories, I know, but that's an uphill battle compared to being able to show something. But actually show it in that positive way, like you say. It's not, okay, I have one model, everyone has to have this. And also, you like, I like what you're doing with the stenosis. You can show improvement, because none of the models did. Like that 3-phase degeneration, it's like, we'll stop you here. But this is,
No, right? It's just, this is like, because it's really about regeneration, right? The best we can, regenerative medicine. You know, how long can we preserve and keep these spines healthy? You know, that's kind of where my, you know, the foundation came from, you know.
Yeah.
And
I'm thinking of, I had this conversation just today with one of my colleagues. She's seen a patient who I'd seen before who, you know, was completely yellow flagged by her MRI report of her low back. And it was typical age-related change. And she's in her 70s. And yeah, she had a grade 1 spondy and these kind of things. It's like, we're probably, most of us are going to have that at that age. And she'd completely freaked out. And she stopped doing everything. And, you know, just me explaining, okay, send me the report. Right, this is what that means. Me just explaining to her what the report meant already calmed her down. But it's one of those things now, that idea is in her head. Like my colleague was saying, she wants to have a chat about the report again. And I know that idea is kind of there in the back of her head. I'm thinking now this would be a great way to demonstrate some of those changes. But I'm also, it's making me think, you know, I shied away from models, and most of us shied away from models because that was what we didn't want, right? We don't want to scare patients. We don't want to leave them feel like fragile or damaged or disempowered. But I'm thinking back and I think I can't think of a single patient who's ever told me that because of a model. Like it was always the words. It was the words that and that's why, you know, there's a push over here. I don't know if it's going to happen, but they're sort of saying, can you stop please sending patients their MRI reports like as a matter of course? Because nobody sits down and explains it. And it's the words that terrify them, you know, degenerative change and all this kind of stuff. That's what freaks them out. It's not actually, like, you could use a model to make words scarier if you wanted to. But actually, all the patients I've seen who've been freaked out or like, oh man, this idea is stuck in their head. Yeah, no model did that. No structure did that. It was words and it was tone and it was, you know, poor communication, essentially, it did that. And I'm just connecting that dot as we speak. So that's, you've given me quite a lot to think about already here. I'm looking forward to using this in an exam basis as well. I like that. Okay, this is it. Let's try the next thing. That's that. Yeah, so I have to say, I think this is great. How many different models do you have now?
I don't know, lots. And I have, you know, and I get like surgeons or, you know, other doctors that want me to craft specialized models, right? You know, I did a lumbosacral transitional model here recently, right? And, you know, a type 3A. And so I don't know, 50, maybe something like that, right? Because all these different conditions, right? And this is where it started. I built one model and I didn't even know it herniated. That's the big selling feature, right? It's like, oh, look at this model, right? It's like, wait, slow down here. It's one feature of it, and you don't need to show it all the time. You can show the retraction too, which is an important part of giving them ideas that, oh my God, well, maybe it's going to retract, you know, which is important too. But I'd go to these conventions and big surgical conventions, and they would say, well, do you have a degenerative spondylolisthesis model? And I'm like, no, but I'd come back the next year and boom, I developed one, right? Okay, do you have a multi-level this? Do you have a this? Do you have a medial branch model? Do you have a cervical disc herniation model? Do you have whatever? Do you have the ligament?
A cervical spine, but yeah, that's a whole thing.
Yeah, it's a whole thing. Yeah, I've developed those too. But yeah, it's just, I've been listening to the professionals, you know, what they want. And then I just figure out a way to develop it and then bring it to market and hopefully, you know, people buy it, right? So
yeah, I think that's a great way because I noticed with this, it didn't come with an instruction of when you have the patient like bend it this way, do this, and that will show them that, because that's not what you're about. It's not about here's the model to make everyone think this thing. It's about, no, here's the model. Now find out what the patient wants, find out what's going on with them, and then look at how you can explain that using this. So it's a very patient-centered model. That's what I really like about it.
Yeah, you've given me some ideas too, because it's often, people wanted like an instruction manual. Oh, do you have like an instruction manual with this? You know?
You mean me not being able to create the extrusion without
No, no, no,
dislocating
no,
the
no, no.
section?
I'm talking about in general, like different
Yeah,
conditions, right?
yeah.
How do you talk about, if somebody's got a radial fissure in their disc? How do you, and it's like,
Yeah, we didn't even talk about how you can see into the disc as well, like, which is a
yeah, the
very cool feature.
progressive
Yeah.
nature, right? So when somebody gets a disc herniation, they're like, well, how did this happen, right? Usually it's progressive. Have you had episodes over the last 2 years, back pain episodes? Oh yeah, but so you could talk about, how wasn't one single event that happened at work, for example. It probably likely been progressive. So that's why, yeah, I tried to show how things can change over time,
Yeah.
as the nucleus finds its way through the annular fissures, or through the annular fibers, and then
Yeah.
finally it breaches, right? So yeah.
No, it's brilliant. I think it's great. And I think it's great somebody's doing it, listening to clinicians and then going, right, what do people actually want? How do you want to explain this to patients, and how do we go from there? It's a shame we got to wrap this up. I would love to do this again with you. Maybe once I've had a bit more experience using this a little bit as well. I might have some more questions. We could maybe do something again in, say, a month or two's time. And I'm going to go, hey, wait, how can you make it do this or that? But just before we go, what's the best place for people to reach you? I mean, I know you've got your website, which we can link to below. Is that the best place for people to get in contact if they're interested in these?
Yeah, dynamicdiscdesigns.com.
Nice and easy. Brilliant. Well, I'll make sure we link to this as well there. But thanks again for you taking your time. I really appreciate this, because you can get a model and you can work stuff like yourself, but obviously you've shown me today several things I didn't even think about with this that you can demonstrate to patients. So yeah, I really appreciate what you're doing, and I'm looking forward to using this more and more, and thanks for taking the time.
Thanks for having me, Chris.
Cheers. Take care, Jerome.